Okay, don't even bother to bring it up to me tonight. I don't know. But she is working remote today, so I talked from
Yeah. I didn't sign it because it's not. It looked okay. And so you can see kind of the.
an hour or I'll be.
Are you guys all set?
Well, yeah, there's no one here yet. I think, I see a few online, but they aren't, I think they're.
Oh, I see some neurosurgeons on.
Yeah, that's all I see. I don't see any of our guys on yet.
Okay. Oh, your guys aren't on yet. Okay.
No.
Yeah, I do have a hard stop at 9. In
Okay.
fact, one of the
Okay, that's
people
fine.
I'm meeting with at 9 is on the call, so I got 1 more minute.
Okay.
Rodrigo, are all your folks there?
No, sir. They also have a lecture at 7. That's probably finishing right now. But they know that we're starting at 8 o'clock, so they should be here in a minute.
Great. Just let me know when they come in, and then I can go ahead and start. I have a tumor board actually in Tanzania at 9. In fact, one of the attendees that's on is going to be part of that call, so that's I have to jump to that one.
Now we're here.
You're all set?
Yep.
Great. Okay,
Yeah.
so you can hear me okay, and then you can see my slides. Is that right?
Yes.
Okay, great. Okay. Well, Rodrigo, thanks again for having me, and thanks for allowing everybody to attend. What I'm going to do over the next 55 minutes, or maybe right at an hour, is to give a talk on the practical approach to imaging of brain tumors. And what I'm going to do, first of all, is really to start out about the history of brain tumor classification. So for me, I trained at the Brigham, I hate to say this, back in the last century from 88 to 92. And the prior chair of neurosurgery at the Brigham and Women's Hospital was this iconic figure, Harvey Cushing, who obviously everyone is well aware of. But one of his partners during that time was Percival Bailey, who he worked with Cushing, and then was actually chair of neurosurgery at Northwestern. And they were the first ones, and predominantly Bailey, I think, from what I can understand, did most of the grunt work, if you will. But at that time, you realized this was really at the turn of the century. We had no imaging. We had very minimal understanding of pathology, if any. And at that time, children would walk in, and Cushing, because he was such a prominent surgeon, was taking out these various tumors. And he was one of the first ones that started to identify that not all brain tumors were the same. And along with Percival Bailey, they wrote this classic article in 1926, which was a classification of the tumors of the glioma group on a histogenetic basis with a correlated study of prognosis. So this really was the first treatise that identified gliomas, because they were actually able to identify similarity in brain tumors. This group did a variety of other subclassifications. This was an article from his, again, a paper on medulloblastomas, or what he felt was tumors arising from the medulla. And really back in the 1920s and 1930s, what was remarkable at that time was to actually be able to look under the microscope, classify similarities between tumors, and then take the next step and suggest that, well, if you have a certain type of tumor, your prognosis is going to be worse. And in fact, when you read some of the review articles about Cushing and Bailey, they were the first ones to identify the poorer prognosis associated with medulloblastomas. And toward the tail end of their career, they were the first ones to suggest craniospinal radiation for medulloblastomas. Again, this is long before the days of CT and MR. Their seminal work led to the beginning of the classification of tumors involving the central nervous system. So the first WHO classification was published in 1979. And the most recent one, I believe, was published in 2021. And I believe these are every 5 years, so there should be one that's coming out in 2026. But because of their work in the 1910s and the 1920s, they really in a for about 5 years, recently involved in the age like so I go to brain tumor conference. Ours is 1 week it's neurovascular, the other week is brain tumors. So I can say with a high degree of confidence that yes, from an imaging standpoint, what we were assured about 20 years ago is not the same anymore, because now in the 5th edition, obviously there is a greater focus on specific molecular biomarkers. So what I've noticed in radiology is that before, if we said a tumor was a tumor, I would say we were pretty good at predicting what the actual tumor was. But what I've noticed now with the 5th edition is what we were sure was a specific type of tumor before is not the case anymore, because now we have to rely on certain molecular markers. So I don't want to say we're necessarily de-emphasizing the ability of imaging to help predict the diagnosis. Clearly play an important role because we can now look for progression or pseudoprogression or look for multiplicity of disease. And it is kind of fun to try to guess what the actual molecular marker is. But I do want to emphasize that a lot of brain tumor classifications and establishing prognosis was really, in a way, de-emphasized imaging when we went to the 5th edition. So the tack that I'm going to take in this lecture is I am not going to go over every single brain tumor. And in fact, this is an example of what I'm not going to do in this talk. So these are all patients that have intraaxial cystic lesions that have mural enhancing nodules. And this was an example of a ganglioneuroma. This was a pilocytic astrocytoma. This was pleomorphic xanthorastrocytoma, and this was hemangioblastoma. Now, all of these look the same. And yes, if I show a slide on this, or if I tell you this patient on the right here has von Hippel-Lindau, then we can make the diagnosis of hemangioblastoma. But when you get out into the wild in the real world and these cases come through, it's really, really hard to differentiate this type of cystic lesion with a mural nodule than other types. So what I'm going to do in this presentation is I'm going to try to stay away from the non-specificity of some of these imaging findings, because as we all know, this is really going to be up to the pathologist to help separate out some of these lesions that look the same. And then also when you talk about the specific tumor type, it's going to be based on really specific biomarkers. But rather what I'm going to do is I'm going to talk about specific imaging features that will help us arise at a diagnosis. Not everything is 100%, but on the other hand, there are certain imaging findings which you as neuroradiologists and as neurosurgeons will help you be a little bit more accurate when you assess these lesions. So the first tumor that we will be discussing is this, and this really I think should be relatively straightforward. It's a heterogeneous mass here that's enhancing, that's associated with a lot of vasogenic edema. These tumors have a propensity to involve the temporal lobe, and they also have a propensity to cross the corpus callosum. I think all of us can make the diagnosis here pretty easily of a glioblastoma multiforme. So in the 5th edition, GBMs are classified as isocitrate dehydrogenase wild type. And wild type means it's basically the unmutated form. And the reason they were kind of referred to as wild type is because when there is a genetic mutation, the normal metabolic pathways or the enzymatic pathways continue, and therefore there's no suppression or no reduction in the mitosis and replication of these tumors. So as a result, when you see this type of glioma and its isocitrate dehydrogenase wild type, that means that this is the characteristic associated with GBM. Now, there are other markers, and they'll probably be embedded more in the 6th edition that can also help identify prognosis. So I know in our brain tumor conference, we look for TERT mutations, but even more importantly, we look for methylations and whether the tumors are methylated or unmethylated. Because if I believe, and I always get it confused, I believe if they are methylated, they have a worse prognosis versus unmethylated. Now, I may have confused that because I always have to look at that. But from us, we always do look at the methylation status too. So this is just the classic appearance of a GBM. Now, what is interesting to me is that this is an example of a molecular GBM. So you have to realize I've been doing neuroradiology since the last century. Again, I always kind of joke on that, but I did my fellowship between 1992 and 1994. And my journey was kind of interesting because I went to the University of Florida for my fellowship predominantly because they had a very strong head and neck radiology program, a head and neck oncology program, so on and so forth. At that time, I just happened to fall into a top 5 neurosurgery program. And that's when Al Roten was there. I showed some of his slides before. Art Day was there. Parker Mickle was there, so on and so forth. So I had this unexpected, incredible experience in neurosurgery. And over time, when I first started my first faculty position at the Brigham, what we noticed that there were some types of quote unquote gliomas or GBMs that did better than others. And we could never figure out, and sometimes there were some astrocytomas that did better than others. And what we have identified, or at least in my opinion in the 5th edition, are situations that look like this. So here's a tumor that's involving this insular region on the left. It's involved with the temporal lobe. It's high signal on flare. It's high signal, on T2. It's high signal on flare. It's low signal on T1, and it doesn't enhance with contrast. So before the 5th edition, we would probably say that this was probably a lower grade astrocytoma, maybe a grade 1 or grade 2. But now what we have been able to do, because we are looking for IDH wild type, when you do the biopsies, this actually was an IDH wild type, and this is what has been referred to as a molecular GBM. And this molecular GBM is characterized by no microvascular proliferation or necrosis, and at least my pathologists tell me it's characterized as a WHO type 3. Now, it's possible it could be a 4 because it is a molecular GBM, but the point is that this has the exact same molecular signature as we see in this. It doesn't have the microvascular proliferation or the necrosis, but because of this specific molecular marker, the IDH wild type, these tumors tend to have a worse prognosis. So in the old days, if I saw something like this, I would say that, well, it's probably a lower grade astrocytoma. But now I always have to put the brakes on because, again, as I mentioned in my introductory comments, we always have to wait for the moleculars to come back to determine whether or not this is more of a benign lesion or more of a malignant lesion. Now, this is an example of a tumor, an astrocytoma, that has what we refer to as the T2 flare mismatch. So astrocytomas, which are non-GBMs, have the IDH mutation. So when you look at the isocitrate dehydrogenase, this has a specific mutation. And that mutation prevents, in theory, the more active proliferation that you can see in the wild type. So that's why the IDH mutations are characterized as a lower grade tumor. So what the mismatch is that you can see on the flare sequences, or excuse me, on the T2 sequences, it's high T2 signal. But when we look at the flare sequence, instead of being bright, so sort of matching the signal, we can see it's low flare signal. So this is what we refer to as the T2 flare mismatch. And as a result, this is supposed to be more characteristic of a lower grade astrocytoma. This is a non-contrast T1 weighted image. We can see it's low T1 signal, and when we give contrast, there's not much enhancement whatsoever. So these are the characteristic findings that we would see in an astrocytoma. Again, you can argue that it does somewhat look like this appearance that we showed before, but the key thing here is that it's the IDH mutation. So when you have this, you'll make the diagnosis of an astrocytoma. Now, this is an example that was always, I don't want to say it's fun for the radiologist, but we can make the initial diagnosis. And this was a patient that would typically present and still do with, sometimes they'll have memory changes, sometimes they'll have progressive onset of movement disorders, and sometimes they'll just have progressive seizures. So this is an example of a T2 sequence in which we see an ill-defined abnormality involving the right subinsular region. Maybe there's an abnormality here involving the left. When we look at the lower areas, we can see abnormal signal involving the bilateral hippocampi. And then when we look at this flare signal lesion, or should say the axial images, we can see something involving the inferior frontal lobe as well, and maybe something crossing over the anterior commissure extending to the contralateral side. So this is this patchy area of increased flare signal in patients that have slowly progressive lesions. And we used to call this gliomatosis cerebri. So from our standpoint, it was an interesting diagnosis to make because we could be relatively confident in this diagnosis based on the imaging pattern. But now we've changed that name, and the WHO now calls us a glioma with an infiltrative pattern. So we've sort of gone away from the term gliomatosis cerebri. So here's a patient that comes in, and what we have here on the left is a non-contrast CT, and when we look at the right frontal lobe, we see an intraaxial lesion that contains some calcification. And then when we look at the flare signal lesion, a very, very large mass right here, we can see on the contrast-enhanced T1 weighted images, it's non-enhancing, and then again, here's a lesion on the coronal images. So the bottom line is that when I see something like this in the frontal lobe, there's certain tumors that have a predilection to arise in this area. So it's intraaxial. When we look at the CT scan, it's calcified. So if I see a calcified mass involving the frontal lobe that looks relatively bad like this with vasogenic edema, then we can make the diagnosis radiologically of an oligodendroglioma. So in the old days, we would call this an oligo. Now, what's happened now is that when the pathologists see an infiltrating glioma and it has an IDH mutation, this IDH mutation takes you out of the category of a GBM. But if you have the infiltrating glioma pattern on histology, you have the IDH mutation, and now you see a 1pQ19 co-deletion, then this is what characterizes an oligodendroglioma. So when you look at it under the genetic analysis, the genetic abnormality is there is an alteration in the short arm of chromosome 1. So I kind of remember 1 is the short arm, and then the long arm of 19 is another loss of the chromosome. So 1 short arm Q19 is a long arm. And when you see this, and this is exactly an oligodendroglioma. Now, this is a lesion that typically presents with seizures. And this was a new tumor, I believe, that was introduced into the 5th edition. So what we see here in the coronal images is an abnormality involving the right temporal lobe. So if I draw a line down the middle, here's a hippocampal formation, and here's the lateral aspect of the temporal lobe. So we can see it's in the mesial temporal lobe. It's with some involvement of the hippocampus. Now, here's a lesion, probably should have been flipped. Apologies for this. There's a lesion here, in fact, on the opposite side. I'll flip that side. Sorry about that. And then here's the gradient echo sequence. And on the gradient echo sequence, we can see some low signal loss here. We can see some signal loss. And then when we look at the CT images, we can again see calcification. Now, when you look at this, you're like, this is the calcification. Is it possible this could be an oligo that's arising in the wrong location? But in fact, when we see a calcified mass like this, that's intraaxial, that has a predominance for the temporal lobe, then we have to think of this type of tumor, which is a polymorphous low-grade neuroepithelial tumor of the young. And this is what we refer to as the plenty tumor. Now, I kind of alluded to the fact that the imaging findings are somewhat similar to an oligodendroglioma. And pathologically, the pathology is actually similar to an oligodendroglioma. But the issue is that it doesn't have this specific marker. It doesn't have the co-deletion of 1p19q, which is characteristic of an oligodendroglioma. So the fact there's no co-deletion tells us that we're dealing with a completely separate entity. So how do we make this diagnosis? Again, realize brain tumors can pretty much occur anywhere. They can look like anything. But with you as neurosurgeons, when people walk in the middle of the night and you see the imaging findings, what are the things that can trigger you to think of this? Well, you have a younger patient. Typically, they present less than 18 years of old. They have the calcifications, and they're typically in a more peripheral location. So certainly if you have a patient that presents with seizures, and then we see sometimes you can kind of lovingly call this a brain rock, which we sometimes do, then we can suggest a diagnosis of a plenty tumor. Now, this is an example of one of these perplexing lesions that I'm kind of curious to see how this is going to evolve over the next few iterations of the WHO classification. So what we have here on the flare sequence is a flare abnormality. On the flares, excuse me, on the DWI, on the flare sequences, we can almost see this bubbly lesion right here, which is involving the subcortical area and sort of extends all the way to the inferior aspect of the cortex. But really, it's more of a subcortical lesion. Maybe with a little expansion, we can see there's no enhancement with contrast. So when you see this type of bubbly lesion here without evidence of vasogenic edema that doesn't enhance with contrast, then we can make the diagnosis of the multinodular and vacuolating neuronal tumor. So we refer to this as the MVNT. So the MVNT was classified in 2021 as a grade 1 tumor. It's been characterized by a bubbly, some people will use the term soap bubble lesion, lesion that's involving in the subcortical area, and it doesn't enhance with contrast. So when we see something like this and we see this sort of bubbly or, again, soap bubble lesion, there's no enhancement, there's a growing trend right now just to follow these with non-invasive imaging. So this, in fact, is a characteristic appearance. One of my former fellows, it's now at NYU, I ran into him a year and a half ago, and I think they have about 50 or 60 of these at NYU. And now they're just following these with serial imaging. I'm not sure what our experience is with UofL, but it may be worth going back and looking at these MVNTs or what we think are NVMTs. I'm sure you're following them, and just to ensure that they're stable. So in general, for us, if we see the MVNTs, we'll probably get the classic follow-up in 3 months, maybe 6 months, and then a year, and then maybe annually after that. And if they're stable again, just watch them. But it's that type of soap bubble lesion that kind of suggests that that's what we're dealing with. Well, here's another lesion that's involving the anterior portion of the right temporal lobe. These patients typically present with seizures. And again, now this one sort of has that soap bubble appearance too, but notice how it's not, as I showed before with the MVNTs, notice how they're not hemispheric. These were more subcortical, but rather these lesions are typically identified in the hippocampus, and this is specifically in the amygdala. And we know that when we look at this area involving the hippocampal formation, there is a higher percentage and a higher density of neuronal tissues versus glial tissues as compared to this area, which has a higher proportion of glial tissues as opposed to neuronal tissues. So if you see something like this, it oftentimes is bubbly like this. Here's the flare sequence. Notice there's not a lot of vasogenic edema. The lesion is non-enhancing with contrast, and on the coronal images, we can see it's very nicely localized to the hippocampal formation. Then really the number one thing that I think about is that the DNET. So this is a dysembryoplastic neuroepithelial tumor. So this is a mixed neuroglial tumor. And back when I was at University of Michigan, one of my senior faculty members, a very smart guy back in the 2000s, was really the first one that introduced me to this concept of a mixed neuroglial tumor. So essentially, a lot of these tumors, wherever they are, if you will, mixed neuroglial. But the ones that are located in the hippocampal formation, because they have a higher incidence or a higher density of neuronal tissue, it really emphasizes that a higher percentages of this combination is of neuronal elements. So again, you can sort of have that soap bubble lesion to it. What are the characteristic findings? Typically in the temporal lobe, and they're non-enhancing lesions. And again, usually these patients present with seizures. Now, I think we can make the diagnosis in this case. This is a patient that there typically arises in children. And on the non-contrast CT, what we see here is an infiltrating and expansion of the pons. And when you look at this abnormality in the pons, the other thing kind of tips you off that tells you you're dealing with something more ominous is the enhancement of the bilateral temporal horns. And when we do an MR, what we see here is this diffusely infiltrating lesion involving the pons. And on the sagittal images, we can see maybe a little bit of enhancement, maybe not. This type of tumor, again, has variable enhancement, but usually the majority that I see tend not to enhance. And when you see this, this is the diffuse midline glioma, the H3, the histone 3, K27 altered. Now, this is an infiltrating glioma, and typically it's midline. It usually arises in children. And what ends up happening is that the histone 3 K27 normally shuts down transcription. But unfortunately, when it's altered, somewhat similar to what we saw when we were talking about IDH, when it's altered, all of a sudden, this one refers to oncogenesis. So it's actually reverse of what we saw in the IDH mutation. So when you have this alteration in the histone 3, this is what's felt to result in oncogenesis. Now, one of the challenges that we get into is on very, very rare occasions, when I see this, typically, especially when the patients present with those symptoms, unfortunately, we're pretty sure it's going to be a diffuse midline glioma. Now, on rare occasions, you can get a rhomboencephalitis. So this really arises in adults and adolescents. So in the back of your mind, the hope is it possible this could be an encephalitis involving the brainstem? And so I remember when I first saw this back in the early 1990s when it was first described, we would include Listeria rhomboencephalitis in the differential diagnosis. But over time, I think the majority of time we see something like this, it turns out to be the diffuse midline glioma. Another example here, this is the non-contrast T1 weighted image looking at the dorsal midbrain. We can see the mass effect that it's having here on foramen magendae. When you give contrast in this case, there was no abnormal enhancement. Here's the T2 signal, here's the flare signal, and you can see why these patients will present with ventriculomegaly, because in this case, this tumor is expanding the dorsal level of the medulla. It's occluding foramen magendae, and here we can see the enlargement of the fourth ventricle, and that obstruction, again, extends cephalad, so that's why you'll oftentimes see the hydrocephalus. Well, here's a classic example, and now we're going to shift a little bit more into the pediatric brain tumor. So this is a sagittal T1 weighted image looking at a heterogeneously enhancing mass involving the superior aspect of the fourth ventricle. So this is arising from the medulla. And this is in a different case. I think I pulled this from the internet, but you can see that this pathologic specimen sort of nicely correlates to what we're seeing on the sagittal images. So this one's diffusely midline. Now, how do we make the diagnosis on this? Well, this is a non-contrast CT, and what we see here is that there's ventriculomegaly, but the point that I want to make in this child is that this lesion has a lot of increased attenuation. So this increased attenuation is midline, it's extending into the fourth ventricle, and it's occluding the ventricle. And when we look at the perfusion imaging, and specifically the CBV, the cerebral blood volume, we can see there's a lot of increased volume. So when you see this combination, then we can make the diagnosis of medulloblastoma. And as I paid homage to Bailey and Cushing, they really were the first ones that described medulloblastomas. So unfortunately, medulloblastomas are the most common malignant tumor of childhood. They're characterized by WHO grade 4 lesion. So back when I was a resident, I always kind of say this, and back when I was a fellow, and even back when I was a junior staff, when I was at UNC and then Michigan, we were pretty comfortable about making the diagnosis of medulloblastoma. Why? Because the thought was, well, medulloblastomas were felt to arise from the superior medullary velum. They were all supposed to be midline. And because they were so dense, of a lot of cell packing, there were supposed to be high attenuation on CT. Well, unfortunately, as with most things, you think you have it figured out and you don't. And what we have seen is in the WHO 2001 classification is that there are different subtypes of medulloblastomas, again, based on specific biological markers. So around 2000 and I would say 18 or 2019, when my friends at St. Jude's were first starting to work on this classification, a very smart neuroradiologist told me, and it was kind of eye-opening to me, was that we could potentially predict the specific type of the molecular abnormality in a medulloblastoma based on the location. So there is this type that is WNT. This is the wingless integrated one. That's why we call it WNT. And in theory, if you see a medulloblastoma and it's involved in the cerebellopontine angle, well, this was supposed to be the WNT activated medulloblastoma. If you have a medulloblastoma that was hemispheric and involved the cerebellar hemispheres, this was supposed to be associated with sonic hedgehog. And then if you had something that wasn't CP angle, wasn't hemispheric, and was more midline, as I showed on the prior slide, well, this is characterized as a non-WNT, non-sonic hedgehog. So the bottom line is that not all medulloblastomas arise from the midline. If you do, then this probably has a higher association with a non-WNT, non-sonic hedgehog. But unfortunately, medulloblastomas can occur anywhere, and unfortunately, they can't look like anything. So we always leave it up to the pathologist to determine this. In general, if you see this type of geographic pattern, cerebellopontine angle, hey, can you guys can you guys hear me again, or when did I cut off? Do you remember?
Like a minute ago.
Just a minute ago? Okay, sorry
Yeah.
about that. I don't know what
Don't
happened.
worry.
Okay, let me go back to thanks for texting me. Appreciate it. This is helpful to you guys. Right.
Yes, it is.
Okay, can you hear me? Yes? Let's see. Can you see my screen again?
We can
Yes.
see your
Yes.
screen. We can see your
Okay,
screen.
perfect. Which tumor did I end up on last time?
You're on a medulloblastoma. I'm sorry, or you're on the sonic hedgehog, exactly, yeah.
Okay, great. Okay, so I think the point that I was trying to make here is that we can't comment on specifically the type of medulloblastomas, but if something is cerebellopontine angle, we can suggest that it may be the WNT activated. If it's involving the cerebellar hemisphere, then we can suggest it's sonic hedgehog. And then if it's midline, then we can suggest it's non-WNT, non-sonic hedgehog. But again, these are only suggestions, if you will, because unfortunately everything kind of looks like everything. Can you see this one then? You can see the perfusion here on this one? Thumbs up. Yes.
We can see
Yeah,
it.
we can see
Okay,
it.
great. Okay. Now you've got me jittery about this. Okay. So in this case, what we see here is a cystic mass involving the posterior fossa, and this, if you will, has a mural nodule. Now, in this case, this is a different case, and we can see again a cystic component to it. And then on the perfusion imaging, we can see this enhancement. So when we see something like this, it has a cystic enhancement, and then the perfusion in the solid component is not as great that we see in medulloblastoma. Well, this is the characteristic finding of a pilocytic astrocytoma. So in pilocytic astrocytomas, they tend to be low-grade lesions. Again, this has the characteristic appearance to it with the cystic posterior fossa mass with the mural nodule. But again, because I've been doing this for a while, I've seen pilocytic astrocytomas that are completely solid. So from my standpoint, if I see this characteristic appearance, that will be my number one go-to differential. But having said that, just realize that pilocytic astrocytomas can occasionally be completely solid. So here's a lesion that is involving the posterior fossa in a child, and what we can see here is that it's involving the fourth ventricle. Now, if you look more inferiorly, this tumor is extending inferiorly through foramen magendae. So this almost looks like it's a little bit softer. And so for the neuroradiologist, I know when I took my, every Monday, I get my MOC where I take my little 2 questions every week. This did show up on one of those questions characterizing this specific tumor. So this is a gradient echo sequence. And what we see here is this area of susceptibility. So if you do see something like this, it's located intraventricularly, and then also has this area of susceptibility, well, this could either represent calcification or blood products. So if you see something like this, you can suggest a diagnosis of ependymoma. So back when I was a resident and a fellow, we would refer to this as plastic ependymomas because ependymomas were felt to be relatively soft, and they would have a tendency to extend through the openings of the base of the fourth ventricle. So in the foramen magendae and foramen of Luschka, it had a tendency to creep and crawl through those areas. Now, when we look at ependymomas, again in the WHO 5th edition, they have now classified ependymomas, again, based on specific molecular subtypes. So if you have an ependymoma that is typically seen in incidence and involves the lateral aspect of the fourth ventricle here, this has been associated with what we refer to as a posterior fossa type A ependymoma. So this is an ependymoma, in this case, extending through foramen Luschka, extending laterally, and this it tends to have a worse prognosis. Now, this is another type of ependymoma. You can see the heterogeneous enhancement. Is it possible this could represent areas of calcification or hemorrhage? It's possible. This usually arises in older patients. They have a tendency to involve the floor of the fourth ventricle and are associated with better prognosis. So the bottom line is, again, there are different appearances to it. You can suggest maybe the posterior fossa B if you see a midline lesion that arises in older patients. But on the other hand, if I saw this, the other thing that I would include in the differential would be a medulloblastoma. So just based on this alone, I think I would have a hard time saying unequivocally this was an ependymoma. So again, you have to hedge your bets a little bit more as we understand the histology and the moleculars better. So the next area that I want to discuss is this, and I think all of you are familiar with this. This is the classical example of a meningioma. So as we know, meningiomas are usually, and I'll say usually, benign tumors. They usually arise in patients between 20 and 60 years old. Usually I see them in 60-year-old females along the convexity that just happen to be found incidentally. They are extraaxial lesions that arise from the arachnoid cell of the meninges, and they oftentimes extend along the dura and the bone. Now, with you as neurosurgeons and radiologists, and as a resident, you should know the classical appearance of meningiomas. But what I want to do is talk about the different types and the different forms of meningiomas and talk a little bit about some of the things that I've seen from my quote unquote so-called experience with meningiomas. So this is just a autopsy image of the skull base, and what we see here is the glistening meninges involving the floor of the bilateral middle cranial fosses. We can see it's involving the lateral skull base and involving the dorsal aspect of the central skull base. So the point is meningiomas can occur anywhere. And some people feel that the location of meningiomas can sometimes predict the specific genetics. So for instance, if you have, as we see here, these multiple convexity meningiomas have been associated with specific mutations, and there are specific familial types of multiple meningiomas. Type 2. So when we, are you guys still there or not? Yeah? Can you see me? Did I lose you again?
Yeah, you lost us again, but we have you back again now.
Okay, I don't know what it is. Maybe my internet. Sorry about that. What did I stop on? The meningiomas?
Exactly.
Okay, yeah. Sorry about that. This is kind of unusual. So anyway, what I wanted to point out here is that anytime you see multiple meningiomas in the back of your mind, you always have to ask yourself, is there a familial cause? So think of neurofibromatosis type 2 and think of the familial entity of multiple meningiomas. Here's an example of a meningioma involving the pineal region. This is an example of a meningioma involving the cerebellopontine angle. This was an example of a meningioma involving the prepontine cistern, and if you look real closely, we can see the extension into the region of right Meckel's cave and here into the left cerebellopontine angle. Here's an example of a meningioma involving the optic nerve sheath, and this is an example of an intraosseous meningioma, and if you look real closely, we can see that expansion of the bone. Now, when we look at meningiomas, the majority, as I mentioned, are going to be grade 1 lesions, are going to be benign. But there are more aggressive forms of meningioma. So the WH2 type of meningioma is felt to be associated with brain invasion. So WHO type 1 is a typical extraaxial mass which just sort of pushes the adjacent brain. But the WHO type 2 are the ones that have brain invasion. Now, what's challenging is that when you go from 2 to 3, to the best of my understanding, we as a radiologist can suggest it, but going from 2 to 3 really is based on histology and molecular markers. So I would, ask if you guys agree with that, but that's my understanding on reading the WHO. So I think as a radiologist, we can suggest that there's brain invasion, but to go from 2 to 3, we really need those molecular markers. Now, one of the things that I have seen over time is the following. So back when I trained, I hate to say this, but when we would make meningiomas, is that what we would do is that we would look for the abnormalities seen on plain film. So I was at the Brigham and Women's Hospital where I did my residency the first time we ever gave gadolinium. So I hate to say I'm that old. So that was back in 1988. So I remember sitting around the console and the attendings were saying, there's a gadolinium. I had no idea what I was looking at. But the point is, before that, we were making the diagnosis on plain films, and we would look for areas of hyperostosis. And similarly, we would also do a lot of angios. And so and no disrespect, I love my mother-in-law, but we were all taught the mother-in-law sign on conventional angiography, where meningiomas were hypovascular, so they would come hypervascular, they would come early and stay late. So we would look for that blush. But over time, obviously, we're now doing more MR. But one of the things that I always want to point out is that in the old days, we would look for hyperostosis on plain film. So I do want to say that when you do have some of these convexity meningiomas, for the radiologist and the neurosurgeons, please take a real close look. Because when I showed the sphenoid wing meningioma here, this was an example where there's an intraosseous meningioma. What I have seen is that a certain percentage of these meningiomas that we see along the convexity actually may be secondary extension from an interosseous meningioma that's arising from the overlying calvarium. So in this particular case, this was a convexity meningioma on June 3rd, 2021 that was resected. On February 18th, 2022, we can see on a routine follow-up, there was nothing there. So you can see the hyperostotic bone that was placed back. We can see a little bit of enhancement underlying the bone flap. But then what ended up happening in June of 2026, we can see the recurrence, and the recurrence is not in the brain, nor is it along the inner table, but it's actually arising from the flap itself. So my sense is that some of these recurrent meningiomas are actually arising from that bone flap. So with me as a radiologist, when I do see these meningiomas, because I saw a run of these, I saw about 2 or 3 of these within a short period, what I always try to do now is pay specific attention to the calvarial flap and to make sure that that there is actually no meningioma here. I think from a neurosurgical standpoint, I think you may radiate these. It probably varies based on your suspicion of bone involvement. But I do want to point out to be, certainly be a little bit more, give a little bit more scrutiny to that area. The other thing that I want to comment about meningiomas, and this was a consensus article that was published in December of 2024, is that meningiomas are felt to be a type of neuroendocrine tumor. So in the old days, meningiomas were just kind of meningiomas. But now what's happened is that they have identified that they do express the SSTR receptor. So this is the somatostatin receptor. So we in radiology, and I know how terrific the nuclear medicine group is at UofL, just fantastic. You can actually now perform the dotatate imaging. So dotatate imaging does have uptake in meningiomas. And so what this consensus paper did show is that at least this group, that's sort of how these consensus papers are done, have now suggested using gallium-68 dotatate PET-CT when they are performing their contouring for recurrent meningiomas. So sometimes, certainly, if you have these perplexing cases where you're not sure something's a meningioma versus something else, a dotatate can be helpful. But now this consensus recommendation did come out suggesting to use the gallium-68 for your gross tumor volume planning in recurrent meningiomas. So the last thing that I want to do is to just go over some of these meningioma mimics. So here's an example of a patient that comes in and we have this mass involving the septum pellucidum. Now it's probably, I think by definition, it would be extraaxial because it's involving the septum pellucidum. When we look at this, we can see the high attenuation, which can be seen in meningiomas, and we can see the calcifications. And then when we give gadolinium, we can see the heterogeneous enhancement. But again, the main thing is that it's located midline. So if you see something like this, then you can be relatively comfortable to include the diagnosis of central neurocytoma. So I remember when we first described central neurocytomas years ago, we would be saying this can't be anything else. But unfortunately, over time, I have seen meningiomas have a similar appearance to this. So I always have to include meningiomas. So central neurocytomas are usually midline. They're often attached to the septum pellucidum. Again, histologically, they're very similar to oligodendrogliomas, but again, they don't have the 1p19q code deletion, and they are classified as a WHO grade. So I make the diagnosis or suggest the diagnosis when I see something that looks like a meningioma that's located in the septum pellucidum. Now, here is a spectrum of findings that sometimes can be very confusing. And again, this kind of illustrates my journey, if you will. So in this case, what we see here is a mass involving the basal ganglia that's associated with vasogenic edema and has increased attenuation. This is a different case on a non-contrast CT, demonstrates high attenuation. Again, this is actually, sorry about this, is with contrast. So this was enhancing. So this is that same kind of appearance. Here we have non-contrast. Now we see it's enhancing. This is the MR demonstrating this kind of bland area that looks more lobulated. This was the same patient on MR. We can see this diffuse enhancing lesion. So these are all from the same patient. In this case, it's multifocal. It contains increased attenuation. So if you see something like this, then you can suggest the possibility of lymphoma. So lymphoma has certain characteristics that can lead us to arrive at the proper diagnosis. So the things about lymphoma that we look at is that they tend to be high attenuation on non-contrast CT, again, demonstrating that dense cellularity. Lymphoma tends to homogeneously enhance. Not only does it involve the basal ganglia, but it has a periventricular location, and it can be multifocal as well too. And the reason why I kind of alluded to my journey is that when I trained in neuroradiology, I was trained in the area of the AIDS epidemic. So in the area of AIDS, patients that were immunocompromised had a higher incidence of lymphoma. So when we saw something like this, we were basically programmed to say lymphoma versus toxo. So from our generation, we became very familiar with this this sort of protein appearance of lymphoma. So we would look for the basal ganglia involvement, we would look for the high attenuation, we would look for this periventricular involvement. So we were pretty comfortable with these imaging findings. And this was a case that we saw probably about 2 years ago in our neurosurgery conference. I remember this was presented and the neurosurgeons felt that this was going to be a meningioma. But what was the thing that we looked at and say, hey, it could be something else? We can see that there's actually an abnormality involving both sides of the frontal lobe. So we can see an abnormality anterior and an abnormality posteriorly. And when we look at the non-contrast T1 weighted images, look at the signal within the left frontal bone. It's high T1 signal. Notice there's signal replacement on the opposite side, but there's no bone expansion. So the fact that there's really no bone expansion here, and this is extraaxial, but it doesn't have that kind of bulky appearance in meningiomas, this turned out to be lymphoma. So when I looked at this, I didn't think it was going to be lymphoma because I do a lot of head and neck. I thought it was going to be retrograde perineural spread of squamous cell carcinoma with calvarial involvement, but the pathology came out to be lymphoma. So the bottom line is anytime that you have something that looks a little bit unusual and we see the marrow replacement in the back of your mind, always think of a lymphoma. Well, just the last couple of slides, this is an example of a patient that has multiple ring-enhancing lesions involving the posterior fossa, involving the temporal lobe. Here's another patient that has a solitary lesion on MR. On MR, this is a patient that has multiple ring-enhancing lesions. And then this was a coronal image in another patient that has multiple lesions, but we can also see abnormal enhancement extending along the cerebellofolia and also deeply into the sulci. So these are just all different appearances of brain metastases. So I know sometimes in tumor boards, you're running through all of these lesions and you're seeing glioma, glioma, glioma. But on the other hand, you always have to stop and check yourself sometimes and say, if I see this ring-enhancing lesion here, could it be metastases? So obviously you have to look, typically they're rounded, they'll have vasogenic edema, they're oftentimes multiple, and they have this propensity to arise at the gray-white matter junction, and that's because the vessels, these end arterioles, end and terminate at the gray and white matter. So that was something we learned years ago. And then certainly if I see this in adult, I would think of lymphoma, but I would also think of adult medulloblastoma. Adult medulloblastoma has a propensity to extend along the sulci of the posterior fossa. Now, there are some advanced imaging techniques that have been described to differentiate metastases from GBMs. What has been described, and I have to say my experience is kind of iffy on this, but I just wanted to throw this out to you because if you do go to different meetings, you may hear this, is that if you are looking at a lesion like this, so we see a mass here and a mass here, what has been described that in metastases, the metastases will end up having increased perfusion, but there should not be any abnormal perfusion in the surrounding vasogenic edema. If there is, then that is more suggestive of a GBM. Similarly, if you perform MR spectroscopy, a metastase should have elevated choline within the central solid component of the metastases. But if you did do a spectroscopy in the edema, there should be no elevated choline. If there was elevated choline in the vasogenic edema, then that suggests that you're dealing with a glioblastoma as opposed to a metastases. Again, this is what has been reported in the literature at some point. I have to admit, to get down to that molecular level using single voxel spectroscopy is kind of difficult. But on the other hand, in some of those areas that you're not sure about, it has been shown at some centers that doing perfusion or looking at MR spectroscopy and specifically looking for enhancement or elevated choline in the edema can occasionally be helpful. And then the last thing that I just want to point out is that not everything that we see are primary brain tumors. This is an example where I know I've seen this numerous times in our brain tumor conference. Here's a non-contrast CT, and we see multiple areas of increased attenuation. These are all hemorrhages. This is a non-contrast T1 weighted imaging demonstrating increased T1 signal. And this is an example of melanoma metastases. So anytime someone presents and they do have multiple hemorrhages, we all know the differential diagnosis. We want to make sure they don't have trauma. But on the other hand, when you see something like this, in the back of your mind, always say, is it possible they could have a melanoma metastases? This was a case that I know we looked at our head and neck tumor board. Our surgeons were sure that this was going to be a primary glioma. But I remember looking at it like this. It was a very, very thin wall of enhancement. Notice on the T2 weighted images, lots and lots of vasogenic edema. And when we did the DWI sequence, it was high signal, which is not 100% accurate, but this turned out to be a brain abscess. This was an example. We see this pretty commonly. You can see the non-contrast T1 weighted image has high T1 signal. So yes, it looks a lot like the melanoma metastases. But what ends up happening is that, oops, sorry about that. My phone just went off. But when you look at the gradient echo sequences, what we see here is evidence of signal loss, and this happens to be a cavernoma. And this is an example that can be a mimic. So you're at the brain tumor conference, you see multiple enhancing lesions. At first glance, you think they're ring enhancing. But the way that you can come to arrive at the proper diagnosis is notice how the periphery of this enhancement is thick, but that margin adjacent to the ventricle, we don't have that same degree of enhancement. So if you see something like this, then you can make the proper diagnosis of multiple sclerosis. So this is what we call tumefactive multiple sclerosis. And finally, on the first glance, this looks like multiple brain metastases, as we see here. But again, in the back of your mind, you always have to ask yourself, could it be something else? And this happens to be septic emboli. So you have to always remember that not all ring-enhancing lesions are going to be metastases. And we always have to consider other differential lesions that give us a similar appearance. So in summary, what I tried to do over the last 55 minutes is joke they are a moving target. Imaging, certainly we do a pretty good job, and I tried to go over the characteristic findings with the understanding that the diagnosis is really based on molecular markers. And I do want to emphasize that cancer is best treated by a team. I really appreciate the opportunity to talk to you all and emphasize a multidisciplinary nature. Continue to partner with your radiologist. And I do have, for those of you that are interested, I have this talk and others on a free YouTube channel. You know, I'm not smart enough to develop an iPhone, but my small little contribution to radiology is this little @Suresh Mukherjee 359. We have about 4,000 followers. So if you want to sign up for that or spread it, I'm happy to have you join and become a subscriber. So thank you very much for your attention and happy to take any questions. Are you guys still there, I hope?
Yes, we're still listening.
Hey, great. Okay, thanks a lot. I've got a couple of minutes for questions if anybody has any.
Someone raised their hand, Dr. Mukherjee. I can't see who it was.
Sure.
Jahanzeb, you can go ahead.
Hello, this is Dr. Shahid, ED Radiology Fellow here at UofL. First of all, thank you for such a comprehensive presentation on brain tumors. I have a quick question to ask. You mentioned in your presentation that for WHO grade 1 tumors or grade 1 gliomas, there has now been an increasing trend that those lesions are sometimes do not touch lesions and are just being followed by imaging instead of going for biopsy or going for anything invasive. Uh, for example, if you are diagnosing something for the first time, is it okay to just follow them based on their imaging features on conventional imaging, or do we need to have any additional imaging, maybe MR spectroscopy, to at least help them grade them a little better based on imaging? Obviously, MR spectroscopy has its own caveats, but at least one adjunct imaging to characterize its grading furthermore, and then maybe follow up that lesion better on conventional imaging, maybe. I don't know.
Yeah, no, it's a great question. I think the specific one that I alluded to was the MVNTs, multivascular neuroglial. I have to look it up. Neuroepithelial tumors, the MVNT. That's the specific one that I looked at because it has that bubbly lesion. Everything else that you're unsure about, if you do have something that looks ominous, then number one, I would certainly, if sometimes to the ER they come as non-contrast studies, I would certainly recommend giving contrast, and I would certainly recommend getting a follow-up on those lesions. And then, talk with your fabulous neurosurgery team and figure out exactly what type of sequence they want to do. So if it's an MVNT, we would still follow those up. But on the other hand, I would be a little less leery about needing to biopsy these, but certainly all of these imaging findings and the follow-up need to be done in close collaboration because, as I mentioned before, I thought I knew all the characteristic appearances 20 years ago, but as I've gotten older and, there's a saying, good judgment comes from experience and experience comes from bad judgment. I've gotten a lot of experience over the last 20 years, so not everything is as straightforward as I thought it would be.
I think
I've
from
got-
our perspective,
Yeah,
Dr.
sure.
Mukherjee, we lean into presentation as well. Like, did they present with symptoms referable to the problem? And do we think their signs and symptoms are related to whatever we see on imaging? And then, of course, when you have like very characteristic imaging that's highly suggestive of a problem that you think is benign, I think that heavily weights our enthusiasm. I think what you're alluding to is diagnostic uncertainty about what it is. I think when we have that, we're much more interested in trying to ascertain what the actual pathology is, symptoms, and then the imaging findings and how concerning they look. But certainly if we find beforehand that it's a more indolent type lesion like MVNT or something like that, we would be, and then we find it incidentally, we would be very interested in just watchful waiting and doing serial follow-up imaging. I wouldn't necessarily, to actually answer Jahan's question directly, I wouldn't require additional advanced imaging, but I think with most of our brain tumors here anyway, we do perfusion imaging, so we get some advanced brain tumor imaging anyway. Spectroscopy, if my neuroradiologist said it would help them, I would order it, but otherwise I might just get a serial follow-up imaging in a short interval and see what that looked like if we were considering MVNT.
All right, I'm going to have to jump now to other meeting. Thanks for having me. It's a real pleasure and honor to be invited. I apologize for the audio issues. And I think our next conference, the next one is going to be on, I think I've got February 12th. Does that sound right to you guys? Ryan and Rodrigo? I'll confirm with Doctor.
Yeah, that sounds right. I can confirm in a second.
Yeah, Feb 12th. I think it's going to be on Central Skullbase.
Yes.
Okay,
Yeah,
great.
there we go.
Okay. All right. Thanks, everyone. Have a great day.
Thank you.
Thanks, guys.
Thanks. Bye-bye.